Here, no lab.
I'm here. Yes, thank you. I heard.
You don't have to answer, but I know you're here. I'm recording already. I didn't even know that. Well, now we're recording. All right, here we go. 12. All right. Remember we were here looking at all this is the idea of what happens, these pathways. And this is where we left off. And I do have a little bit, but I'll probably just say it's just on the EEGs. I thought we could do EEGs with the technology we have, but I'd have to order a piece, and I don't want to do it for budgetary concerns. And I'll talk to Dr. Badger about it and see if he can find some money for after, when we do physiology in the spring. So the big word here is this: decussation. Most pathways cross over, and we're from right to left, left to right, all that stuff. The word to remember is decussation. Most is a good term. All is not the appropriate term. I showed you some of those pathways will go on the same side. You were going to point that out. I was going to do cranial nerves today in lab, and I can probably do that remotely just as well as anything else. But to have you understand that some things are only on one side, they don't all necessarily cross over. They cross over limitedly. So again, and now we're going to look at these chains of 2 or 3 nerves that are there. And I'm not worried about somatotopy, and inevitably we see symmetry. But this is spatial relationship in the central nervous system correspond to certain areas of the body. It was part of that homunculus thing we looked at. Okay, when it comes to ascending pathways, sensory pathways, typically it's a 3-nerve pathway. And we call them first, second, and third order neurons. The first order neuron comes from the receptor. I touched this and it felt hot. Okay. Conducts the impulse from the cutaneous receptors, proprioceptors. So I reached out and touched it. I wasn't even looking at it. I go over that box. So not only is it hot, I can get an idea what it feels like. Diffusely as it enters the spinal cord or the medulla, depending on whether it's coming in from a source, higher in the cranial nerves, and then it synapses with what's called a second order nerve, the next nerve. The second nerve is an in-between nerve, an interneuron. And typically, remember, sensation comes in dorsally. You'll see this in the illustration shortly. The cell bodies come in dorsally in the spinal cord or medullary nuclei, okay? And so they're going to come in there, and the axons then extend to the thalamus or the cerebellum. So you're going to see that from wherever it's thin synapses, okay? The next place that nerve ends is the thalamus or the cerebellum. And the third order, also an interneuron because it's not its destination, is typically going to the thalamus. If it's one of those tracks that, like said, spinocerebellar, it's just going to be, there's no third order neuron, it just goes to cerebellum. That's one of those proprioceptors. Uh-oh. I know where my hand is and where I'm touching. A little bit like that. So you'll see it. So the main pathways that they travel, okay, this one, the dorsal columns, and if you go into graduate anatomy or medical anatomy in graduate levels, you're going to hear about dorsal column and medial lemniscus, and all. You don't have to know that. The dorsal columns are really important. If you remember, we looked at the spinal cord. That's that large amount of white matter in the back. In the spinal cord. I'm sure you'll see it again, and I'll point it out. That's most of the information going to the cerebellum. That's all that proprioceptor stuff where I know where I can feel with my feet, or that type of thing. You just have that idea, that whole idea of Romberg sign, the cerebellum. Interestingly, there's a disease it's still around. We don't see it anymore because it's very treatable. And it's probably the first really recognized venereal disease since it's been around for a long. We're talking again. Hieroglyphics talking about it, is syphilis. And one of the findings of syphilis when they didn't know enough about it and didn't have penicillin and things like that to treat it was something called tabes dorsalis. Dorsalis meant the dorsal columns. Tabes had to do with a move. Again, we look for gait disorders. And they would have, remember, like The drum, they have that kind of an odd gait. So that was that meant tertiary syphilis. And tertiary syphilis, brain damage, it's a shortened lifespan, and most likely people have passed the disease on to their children without knowing. So syphilis used to be a scourge, and if you did not know it was syphilis, just to amplify the point, when people used to get married in almost all states in the Union, I think since Union, other than West Virginia and Nevada, you had to have a blood test before you got married. The blood test wasn't to stop you from getting married. The blood test was to identify syphilis. And if you had it, then it let the health departments pursue it. When people wanted to get married fast, they went to either West Virginia or they went to Vegas. So my first wife, we got married in 78. We had the blood test. And then when Patty and I got married in 2013, we didn't need it. We were in California for that, San Diego. So it gives you an idea of how, I don't know when they stopped using the blood test, but, it was 77, 78, gonorrhea and syphilis were running rampant. I do a little unit on that when we do reproductive. It's there. Back to that. So the dorsal columns are affected. Spinothalamic, that's pain. Okay. All of that. And then the spinocerebellars, again, another one that terminates in the cerebellum. So all of them are different pathways. Really, the spinothalamic is sort of what we look at. This is discriminative touch and vibrations, doesn't matter. You don't have to know things like fasciculus, cuneatus, and gracilis. I did. The spinothalamic is the one that concerns us. There's lateral and ventral. I showed you on that chart. Pain, temperature, coarse touch, pressure. I mean, think hot, cold, sharp, dull, temperature, all of those types of things. Those are the ones that get you, particularly pain. So do remember that one. And these other ones, again, a lot of this is just conveying information, tendon receptor, it's your body's processing all this unique information you don't have to think about. Right? You're going to move things and coding it for future reference. Useful. So the illustration's a little bit easier if you take a look at it to go through. So here, graphically, so we're going, let's say the bottom of the foot, I stepped on something. Here's that first nerve, and now, depends on where it crosses over. Some of them will synapse, in other words, synapse, but this one it continues to go up, as you will see. And again, the synapse starts over here, and then you follow the thing up from where it's going, and then it goes up into the medulla, and then the thalamus, and then so the first order neuron, the second order neuron for this one happens to be in the medulla, then it crosses over, goes to the thalamus, and the thalamus distributes it to the second. That's what I mean by first, second, and third. They don't always cross over in the spinal cord. Sometimes they do, sometimes they don't. So you'll see ones, if you go on with your studies, you'll see different ones cross over in different areas. That's sort of the roundabout point I'm trying to make. So the generic type of question would be, in a sensory nerve circuit, are there two nerves, or are there usually two nerves or three nerves? There are three nerves. And maybe it would be the first, second, and third order, or there's just first and second. And if I said, lateral spinothalamics, you would probably know which one it was. Bingo. And so these are pathways of other selective. Here's a different one. I'm trying to see which one this is. Now this was just temperature receptors, and you'll note it crosses over here. So I'm not going to ask you that detail. And then it works its way up to the thalamus is the second, and then bang up here. So there's different areas that it can go to, just to give you some context. And they describe it here. And again, more detail than you would do. So lateral spinothalamic, interneurons and dorsal horns, fibers cross the opposite side before ascending. And that was the one I just showed you. The last one was spinothalamic, to correct myself. Which means I have to look them up. Just so be familiar with that. And then there's these ideas of direct and indirect. The most important direct pathway is the pyramids or pyramidal pathways. Those are the classic upper and lower motor neurons. Talked about that with regard to amyotrophic lateral sclerosis, Lou Gehrig's disease. It involves both pathways that are there. That's why it's such a unique disorder in many ways. And everything else is, when they say indirect, it's sort of supportive. So the pyramidal neurons, we know where they are in that precentral gyrus, primary motor gyrus, through pyramidal tracts, both lateral and ventral corticospinal, descend without synapsing until it reaches where it's supposed to be in the spinal cord. In the spinal cord, it synapses with the interneurons or ventral horn neurons, depending on which track it is. But effectively, it's usually a two-nerve circuit and a very, very fast, fine, skilled movements. So without going into all the jazz about this thing, that's what you're trying to do. The bulk of it is a two-nerve circuit. So it goes down on one side and it crosses over when it gets to the appropriate area. Spinal. And you'll see some of them are like that, and some will actually decussate here. It depends on the pathway. They'll decussate in the pons, cross over there. It depends on which one it is particularly. So you can see a lot of these things. So I don't want to go through all of that stuff and reticulo and rubro and tectospinals and blah, 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 blah. But they'll summarize it there. I'm trying, it's hard for me to see because they changed this. All right, there we go. This is just showing that MRI, and probably better with the lights off. It's just showing all the, I mean, there's an immense amount of tracks, as you can see. There's so many connectors. Basically, that's done, other than me making a little comment separately about electroencephalographs. Not a lot for me to say about that, because I don't know a great deal about it. And I could do it here just as easily as anywhere else. Maybe I will, just so I don't have to think about it again. Yeah, this stuff. Memory's too difficult. The big area for memory is certainly the hippocampus. That's a lot of your working memory. Okay, there's all sorts of different kinds of memory. It's really something. I'm extraordinarily fortunate to have a great memory on one side, and trying to explain it is just not something I can do satisfactorily. And so short-term memory, and I think that's wrong. I mean, I don't know about you. I'm not limited to 7 or 8 pieces of information. You know, it's what I like to call walk and chew gum syndrome. I can do more than what I do. Maybe not as many as I used to. And that's very, and you can, there's so many, you really want to expand it, depending on where you're going with your careers. If you want to work on expanding your memory, there's a lot of resources that are available for ways to help expand your memory in a variety of ways. Depending where you're going, you may need it. It's not always that easy to be able to look something up. And again, and so all of these things. So to transfer it, alert, motivated, surprised, around, you learn. It's like you learn from your mistakes. You learn for things that you can put in there. That's why in a field, whatever field you're in, when somebody, a lot of times if they do it politely, that's what really constructive. You know, you botched that, but you know, you did good. This. You'll see the way people talk to you. Watch out when they say, you know, Lou, I hear you're doing a great job. That but is coming. And usually it's like Dr. Badger, you know, hey, Lou, could you stop by the office? What did I do now? And it's always, oh, Lou, nothing, everything's fine. I just need you to sign this and put this out. I'm good. The minute he comes in and goes, you know, you've been doing a great job, that but. So you got to be prepared for these kinds of things. So when you make an error, and that's how, if you're in a subordinate role or you're in a leadership role, you got to learn how to interchange with people to get the best out of them. And that's where this comes from. You know, encouragement, pointing it out. If you're going to have to say something critical, start with encouraging, then critical, and end with encouraging. There's all sorts of techniques. I have the privilege of having a son who is an expert in this. His management skills are his genius. And I mean, it's not, because to demonstrate to a lot of people how you don't have to be a particularly gifted academic student to achieve great things. Because I'm fond of thinking everybody has their own genius. The rote memory, and if you're doing this to study, it's whatever works for you, don't change now. But that sitting there repeating it and going, superior orbital fissure, superior orbital fissure, superior orbital fissure, it doesn't stay in long. If that works for you, that cramming the night before, worthless. I'm telling you. Got to try to continually, the best time to study is after the lecture, that type of thing. And tying it with something is great. All of that. You've got to parcel it in. Oh, that was really interesting. So all of that, the hippocampus is really critical. The processing, the thalamic processing, the prefrontal cortex, that really is the richness of our lives, emotions and things like that, I think play an important role. That's my sermon on memory. Okay, and then the different things that happen are different kinds of amnesia. I'm not enough familiar with these types of things to be able to describe. One thing about amnesia, they did used to use, that's where smell. They would find familiar smells and try to jog people, particularly if it was a traumatic amnesia, in a sense. Some event happened and they were almost in a state of shock. It was like, they were, saying throwing cold water on them, just trying to, when they were, think about being hysterical and breaking it. Sometimes smells would do that from a state of amnesia. So smelling salts sometimes was useful for that, particularly smells that would trigger it. And so the EEG are just, it's electrical activity. And just like an EKG, an electrocardiogram, you basically can measure these and deduce information. This is how you diagnose seizure disorders. This is how you diagnose sleep disorders. Okay, and it's non-invasive. That's the beauty of it, because you don't have, same thing with electrocardiogram. You're putting leads on the surface and you don't have to stick things into people. And that's why I have the stuff set up now, and we'll do electrocardiograms that are there. So electrical activity with brain function, epilepsy, sleep disorders, and people who are skilled at this. Years ago, before CT and MRIs were standard in every hospital, every big medical institution, neurologists used to sit there and read the EEGs. I was tagging with one, and he's dictating, and he said, "Oh, there's an irregular disorder in this whatever lobe." Just looking at these patterns, which just to me look like jagged lines. Okay. And yes, and very medical legally very important, because brain death has to do with serial electroencephalograms. Brain death is death, and medical legally that's very significant. There's a lot. It's sad when there's a lot of decisions about that. Very, very sad. That's the whole idea with advanced directives and those kinds of things. My mom was very good about that. My mother-in-law, and she died February of last year at age 98 and a half. I mean, we certainly weren't going to attempt any heroic measures. We knew that was her wishes. I do not know if she put that into print with signature. I do not know. So electrodes are placed on the scalp in different areas and measure activity. So, I mean, that's kind of what it looks like. The best way is directly to the scalp. So typically you can move hair away. Maybe, a lot of times you'll take like fine sandpaper and roughen it up a little bit. They do that for electrocardiograms as well. So it measures all this activity. They're very unique to you and all the changes. 4 different categories. I'm not going to ask you a single question about it. Don't know. This is Dr. Buxton territory. When I see Hertz, I think of him, or I'm getting a rental car. And we usually go to Alamo. We do. You get frequent flyer points. Alamo, National, and Enterprise, I think, are all in the same family. So they're different waveforms, and that's what it looks. I mean, I'm watching him going through papers like a book, knowing where they go. Well, seizures. torrents of electrical discharges by groups of neurons. Okay, and what happens is, now we get to, years ago we used to call it epilepsy. The appropriate term is seizure disorders, and they're not all the same. Classic one that you think of, we used to call grand mal, really bad, is now called tonic-clonic. That's the one you see that make they lose consciousness, fall, uncontrollable jerking. Another and this is a big mistake people make. The fact that someone has a seizure disorder, whatever, is not a sign. It may be associated with intellectual impairment. It is not. The two are not linked whatsoever. Same thing. Same thing with cerebral palsy. There may be intellectual impairment. It is not part of the diagnosis. Trust me, I'm sensitive about that. My granddaughter, my 8-year-old granddaughter, has cerebral. 1% of the population, bigger factor than you think. But all of these, injury, stroke, infections, tumors, all play a role, particularly if they manifest themselves at some juncture when we don't see them early on, I would think. If they're diagnosed early, you begin to think of the different kinds of the genetics or things like that. When you have injuries and stuff, it's pretty self-explanatory. So the good news, if you did not know, most of these folks get some kind of an aura. It can be olfactory, it can be visual, it can be somehow sensitive, and it gives them, it's a thankful moment that they can get themselves someplace where lying down, so whatever in some way that they're going to prevent injury to themselves. And basically that's the tonic-clonic, lasts a few minutes. The thing that you worry about is it doesn't stop. That's called status epilepticus. That's a medical emergency. You have to use some kind of medication to break that cycle, because they're not going to survive. So bones broken, bowel, and this is the stigmatizing event. Bowel and bladder control loss, the tongue thing. Okay. If you see somebody starting a seizure, the notion that I've got to get something and stick it in their mouth, if you want to be able to count to 10, don't do that. Okay? Don't do that. You know, in my office, it's changed because I don't see it in my doctor's offices now. We had 2 things taped to the wall: a padded tongue blade, if somebody seized, and smelling salts. I don't see them in my PCP's office. Don't. Rules changed. My office was certified for HMO usage by UPMC when they just started doing it 30 years ago. So, I mean, I followed all the rules. My first wife, wonderful nurse, she took that one. I didn't tell you this one. The one. She's the one. Is there a doctor or a nurse in the house? She'll go running. We were in the Carnegie in the museum, and in one of the areas, all of a sudden there was a commotion, and you saw it was mentally handicapped individuals who were in a group went down. She flew in there, and all she did was nothing with tongue blades or putting something in her mouth. All she did was hold her head, and it came back out, and yeah, there was incontinence and all that stuff, and that's the stigmatizing thing. And she came back, and I said, "Why did you do it that way?" She goes, "We were trained as nurses. It's just the biggest problem is they particularly on a hard surface, they can hurt themselves. You give yourself a concussion, fractured skull, that type of stuff. So just hold their head." And that's what they told us. Don't go sticking things in the mouth. Once it starts, if there's a finger in there, you're going to lose it. Point. She's that one. Okay. So, and different things they do. And now I missed one. This is in children. They're used to be called petit mal. The child will be just there, and all of a sudden, "Oh, I wanted to talk to you about what happened last night." That's an absence seizure. Very young, blank, and so and there's other variations, of course. Anticonvulsive drugs, various things are used. It's been around forever, and I don't do a whole lot with consciousness or that kind of stuff. This is the difference. Another word you hear for fainting is syncope. I always spelled it with an E, but that's me. Usually due to bad blood flow, but there's things. Hypotension, as people get older, they stand up too fast. The blood doesn't get to their brain. We're going to talk about that in physiology. And certainly emotionally, temperature plays a role. I mean, and some people faint They faint at the sight of blood. My daughter faints at needles. I mean, she was going in for a blood test, and we told the guy at the lab tech, well, she's going to faint. Well, I heard that. And it's like, puts her in a chair, does the venipuncture, she looks as, this was mom and dad. She was like 12, 13. She fainted. We told you she was going to faint. Open up your ears and listen, blank, blank. Second word ending in hole. If you're in a medical profession, don't be that person. I once had to tell an anesthesiologist, reminded him that he's human. This is my ex. Her veins roll. She's a difficult stick. I would do it there. Well, I've been doing these for a long time. If they're trying to stick her about 4 times, and he's like, you could see him getting ready to turn away and huff. I said, medicine is a very humbling science, isn't it? He didn't have a word to say. Yes. Listen to me. Let me tell you, listen. Coma. Not the same as deep sleep. Different. Like if you lift up somebody's arm when they're sleeping, there's still a lot of muscle tension. Like this, you can feel it. Comatose, there. So everything kind of goes on shut down, and then brain death, whatever the legal rules are. And I don't do the eye movements and the types of sleep. I sleep lousy anyway. Really? I'm there. A lot of times I'm coming in here, maybe I've had 2 hours of sleep. I know I'm not a good, and these are funny conditions like this. Historically, you went for narcolepsy. Okay, people just, I'm telling you, they just fall asleep. And there are people who have that, okay, and this is probably destroyed by the patients, probably immunological. There are treatments that are available, okay, and insomnia, again, different things, but I don't know enough about them. And then we did the unit with the meninges and stuff like that. So that really summarized a lot of what blood-brain barrier, should put that in. And that's what happens. The hydrocephalus is when there's an obstruction. Again, it's a very compelling picture. But they treat those with a shunt. Yes, sir. I do not know, but I don't doubt it. I don't know. It's not my area of expertise. Things like that. I mean, it would not surprise me. They get a lot of things. Sometimes they manifest themselves different. It's like dogs, their allergies, everything is manifested in their skin. It's like that. So I didn't know all about that stuff. And then, he went to be groomed. He said, I call the vet. Give him a Zyrtec. It's a dog. So short answer is I don't know. Dogs have a lot. Dogs have diabetes. Dr. Hilwig has had a cat with diabetes, I think. Pretty sure. That's not unusual. So their physiology is very similar. And there'll be more. Short answer, I don't know. We should look it up. Probably don't tell you. So all of these things, the whole idea, what happens is those tight junctions are so abundant. Okay, they create a barrier. On top of that is when we get into the cellular aspects of physiology, the lining cells, okay, they have an additional layer of cells called neuroglia or glial cells. These glial cells are called astrocytes. They envelop the capillaries. The capillaries in your circulation there have the tight junctions. That's the principle. Then it's reinforced by glial cells, and the glial cells, which have a lot of membrane, it's as though the material has to pass out through membrane, through the glial cell, and then into and it embraces the nerve through membrane. So they have to be fat compatible, lipid compatible, soluble agents. And so the tight junctions pass through around the endothelial cells. The astrocytes surround them, so they help to promote the tight junctions that are there. So it's a marriage of the two, but the tight junctions are the main barrier. And so it's effectively lipid soluble, simple diffusion, oxygen, carbon dioxide, of course. And then there's special transport membranes, Okay, to transport for things like that. The brain has to have glucose. It only lives on glucose. And again, the amino acids are probably amino acids. And you're studying, many of you are studying biochemistry, the ones that would be fat soluble as opposed to water soluble. All those R groups. That's her. Did you have that test yet? Oh, you know what I'm talking about. And so that's really, and that's why, for instance, we can't use dopamine a lack of dopamine is implicated in Parkinson's traditionally. We can't administer dopamine water soluble. It's an amine. You guys know that already. You know what amines are. Okay, so what happens is we use L-dopa, the precursor substance. And so what you're doing is you give more of the ingredient, the presumption is that you'll make more dopamine. So that was always the original trick. There's not a great, but an interesting movie with De Niro and the late Robin Williams. That's based on a true story of one of these doctors who, the name's got to come to me. I hate when I do that. The movie itself was not what I would call an Academy Award movie, but it's really Awakenings. So he played a guy who was, and we did a lot of point. There were a lot of inpatients with mental illnesses, both physical and psychological, were kept in units. There was a lot of outpatient units. The tendency changed, and he was giving him increasing doses of L-dopa and got him to come out of this. That was the way that was the story, and it shows his interactions and what transpired as a result of that. So it's a good watch. I mean, and the late Robin Williams, very, very tragic. Having taken his own life. It's just so sad. What a waste. Getting here. Almost there. I'm letting you guys out in a bit. Am I done? Yeah, we're done. I think. No, that was the other. Get a grip loop. So again, that's how that works. So here's the blood-brain barrier. I'm showing it to you. Thick basement membrane, certain chemicals that would activate brain neurons, absence in certain areas. The hypothalamus is where your body senses levels to make adjustments vis-a-vis feedback. Sugar levels, salt levels, etc. Calcium levels. So in monitoring the chemical composition of the blood and other areas that trigger toxins. Vomiting is induced by a rapid increase in toxins and because they're protective in nature that are there. And then again, the brain injuries are a list. The concussion, by definition, temporary. The problem is successive concussions in a short period of time. And that's when you go from first degree to second degree. What happened to Sidney Crosby? He played with a concussion, and they had that game, not the one up in Buffalo, but the next one that was here outside of, in the stadium, that he got nailed again. And that was probably in a 2-week period. I mean, he basically missed most of that year because of that. I mean, thankfully hasn't missed a lot of time since then. All-time great. There was a player who was the #1 overall draft pick who was going to be great. His name was Eric Lindros. He got, and what really clobbered his career, he was never what they thought when they traded him from Ottawa. At the time had a team that became the Colorado team. It was the Quebec Nordiques or Ottawa that traded. The Quebec became Colorado, and they traded Lindros and to the Flyers, and he was very good for them. And then in a playoff series against the Pens, Darius Kasparaitis, who was this little guy comparatively, very strong, 5'11", muscle defenseman. It's the stupidest thing in any hockey. They tell you heads up hockey. Always keep your head up. He had his head down. Didn't see Kasparaitis. Wasn't ready for it. boom, nailed him, and basically nailed him in a body check, but his head. And he ended up with a very severe concussion. It was never the same. Had to get a plane to land because all of a sudden he was extraordinarily sick near death. On like a plane that they were moving. Very interesting story. So contusions permanent. And I wouldn't ask you, but it's my understanding that they were reversed in spinal cord. And then the different areas where you can get a bleed, and those are all bad because you're forcing the brainstem deeper. You're going to put pressure. The brain's in a closed case. Fluid all it's going to do is damage stuff. We have a limited amount of space. Any additional space in there is going to be potentially devastating. And then when you talk about a stroke, cerebrovascular accident, this is the equivalent of a heart attack, cardiovascular accident. Typically, it means, and this is the definition, tissue deprived of blood supply leading to death. So the fancy name for it is an important distinction, a really important name. Remember, I probably told you before. Infarction. Infarction, death of tissue from lack of oxygen. Period. Whether it's certain cells require oxygen, brain cells and heart cells. In their absence, whether it's absolute, in other words, there's a giant clot, or it's relative, there's not enough, the supply and demand issue comes into play, economics 101. What happens is it dies. And so there's any of those things, blood clots, blockages, fluid from another area pushing on the brain, restricting the flow, whatever. And what happens is, we'll get to it when we look at the physiology, glutamate, glutamic acid. I believe that's an amino acid. And glutamate, why do they call it glutamate? Because it's dissolved in water. And so the 8, aspartate and glutamate, are usually they're neurotransmitters that inevitably are excitatory. Very rare that they're not. And that makes it worse. And that causes the contractions in the muscles and the muscle spasms that are associated with it. And again, what happens is flexors always overpower extensors. They're typically on the opposite side, almost exclusively. Left-sided stroke, right-sided hemiplegia. To the paralysis, and once the paralysis is over, then the spasticity, and they become spastic paralysis. It's very difficult to rehab from that. And so these are not mini strokes. People, grandma had a mini stroke, but she's fine now. That is a TIA or TIE, transient ischemic attack. That is the alarm clock saying, please do something now before you have the stroke. Because if it's transient, it's reversible. And things that we can do, we use this. We'll get to it in clotting. TPA, tissue plasminogen activator. That's the clotting cascade does 2 things. Not only does it make blood clot, once the blood is clotted, it initiates the next mechanism to break it apart. Or we'd have clots that never went away. Tissue plasminogen activator is a relatively simple polypeptide we make genetically. If you get it into the person soon enough, you're able to revert the damage. Will effectively be reversed in the sense that they have the damage, but it's not permanent. Years ago, they used to use a streptococcal enzyme. They used to use what's called streptokinase. Streptococcal infections are highlighted by spreading factors, and so these are enzymes that are proteolytic enzymes, streptokinase and streptokinase. If you get a lot of times you get a strep infection, the skin spreads all over. Nasty. And that they used to use that, but because they were not, again, you're getting it from a microorganism, there's a certain inherent danger with this. So this is a lot more specific. I had an aunt who passed on now, she was living in Florida, and all of these facilities, all the hospitals and care places there, they get into a hospital that has this right away because it's God's little waiting room. It's the old joke, pardon the religious context. What's a Jewish wine? I want to go to Boca. I want to go to Lauderdale. So and she was in either Boca or one of those areas down there. Nice place, Lauderdale. Might have been up a little bit toward Palm. That's the East Coast. My best friend's been living there for 50 years. Now he's retired up to Port St. Lucie. He lived in Palm Beach Gardens for ages. He still plays golf really well. Another one. I am not, I may not do this unit. Alzheimer's become, as if we generically refer to people with dementia as Alzheimer's. That is not. Alzheimer's is an interesting disorder that, I mean, it's one aspect. There are certain, this is the idea. Proteins that appear misfolded and malfunction, if I said it was a microorganism, what would you identify it as? What microorganism makes misfolded proteins? Did you get this in micro? Okay, when you did the unit on viruses, did you talk about another acellular form that caused damage? Prions, protein infectious particles. Prions are misfolded proteins that induce other proteins to misfold. Okay, so we think, at least we were very confident, because I had a student whose husband was a researcher at Pitt, was doing research. About 5% of Alzheimer's cases are directly related to prions. There's a lot of thought that it could be some type of prion basis. And a lot of people think prions are all one disease with just variations. Mad cow would be the classic example of that. And all of these, memory loss, short. And it happened to my mom, who had my kind of memory, who had, all of these things. And basically what happens is your body, it's like going in reverse. You reach your plateau of development, and when it starts to manifest itself, now all the things like your short-term memory goes, and then functions start to dissipate. You have difficulty swallowing, going to the bathroom. Well, imagine degressing like you were as a little kid. All those landmarks. Then all those landmarks the parents love, you're starting to go there in reverse. So eventually they can't swallow. I mean, they choke on. You have to give purees, not liquids or salt. I mean, there's so much to elder care in that regard. And so thankfully it was, she was gone in a sense of here, for the last year. And this is some of the things that's notable. These plaques. So it has neurofibrillary tangles. We'll look at neurofibrils. It has neuritic plaques, and it has chromatophilic pigmented deposits all there. These are all part of it. And the brain begins to shrink. And now we can see it MRI. We used to only make the diagnosis post-mortem. But in the MRI, now we can compare certain areas and use PET scans and MRI scans to do it. So it's pretty, there you are. So here you're seeing a scan. And I mean, normal, this is a PET scan, positron emission scan. It tags to glucose. So these guys that are lighting up, active, normal. Not lighting up, not normal. And you can see a lot of it back here, a lot of temporal lobe, which is a lot where memory is stored. And there's Parkinson's, dopamine from the substantia nigra. That pathway, the nigra striatal dopamine pathway, okay, and what happens is they're deprived of dopamine, they behave irregularly. That's what we think. There's other theories. This is the dopamine precursor. Other things that are there. I mean, I don't know enough about it, but you should be aware of the relationship to dopamine and that pathway from the midbrain, the substantia nigra, to the basal nuclei. Nigrostriatal, that's the corpus striatum. That. The other way we link it is with addictive diseases. That's the mesolimbic. The limbic is your pleasure center part of it. Meso means midbrain, also dopamine. It's not, I mean, they're not all clear. Addiction is a very, very complex area. I have a lot of practical experience with that. You don't smoke for 40 years. I have a very addictive personality. And here's the Huntington's, the accumulation, deterioration of the basal nuclei, the jerking. You can read that. Again, they're doing some research with it, and there's not a whole lot. All right, guys, I'm barely able to talk and focus. I apologize. I'll make it up to you. I promise.